Well, thanks so much for watching Making Healthcare Work for You, Different Perspectives and Empowering Solutions. I'm Stephanie Fields, joined by my co-host, Dr. Apoorv Gupta, and today we're welcomed by Dr. Hamilton Baker, who is an Associate Professor of Pediatrics and Public Health and the lead of the Clemson-MUSC AI Hub for the Medical University of South Carolina. Thanks so much for being here.
Well, thanks for having me. It's a pleasure.
We are happy to talk to you today, and we're talking about AI specifically and how that applies to medicine, to your everyday work, and also how you're getting these innovations from somebody's brain into practice. So why don't you start by telling us a little bit about what is the Clemson-MUSC AI Hub?
Yeah, so the Clemson-MUSC AI Hub is a collaboration between the two institutions that's mission is to increase research in the area of artificial intelligence and machine learning in the biomedical sphere, to build teams across the two institutions. It was started about 4 years ago by myself and Dr. Jihad Obaid at MUSC, and then grew across to Clemson, and is supported by the provost offices at both institutions.
So it's interesting. What kinds of projects is the hub supporting, and how far along have you seen those projects develop? Earlier, when we were talking in the pre-interview, you were talking about particularly some of the challenges in moving projects from the research stage into the clinical stage. And so I'd be curious to know how the hub is helping with that as well.
Yeah, that's a great question. And I think it kind of leads into the different components of the hub and how we support these projects and get them off the ground. And so, one of the main components of the hub is a seminar series that we have every 2 weeks, where we bring in speakers from MUSC and Clemson, but also from across the nation and from startups and industry. And that's really to stimulate people, to get them as part of this community of practice that the hub represents for AI and medicine. And from there, we increase interest. And one way we're able to get folks that are interested in this area and help them integrate machine learning into their research is a consult service that we have through the Clemson-MUSC AI Hub. And what that consult service provides is that researchers, either in clinical or basic science, any area really in biomedicine, that are interested in integrating these methods into their research, but don't necessarily have the expertise to do it, can come to us for a completely free consult. And that includes all the leadership of the AI Hub. What we do is when they come to us with their research question, hypothesis, et cetera, we help them figure out how they can apply machine learning methods in order to improve or augment their analytics. From there, if we agree that it seems like a project that makes sense and a way to integrate machine learning, then we help get them connected with the expertise. And that's where this community of practice and the network of the hub becomes so important, expanding across both Clemson and MUSC. Because what it allows us to do is identify those that have the technical machine learning expertise to help these researchers, and we pair the two together. And through that, we create amazing collaborative teams. And that's really where those projects that you're talking about come from. Fortunately, with the support of the provost office of both institutions, we've been able to have the funding to provide some pilot funds to get some of these groups really up and running towards extramural funding. Some specific examples are the identification of diabetic macular edema in patients just by looking at a picture of the back of their eye. Some other grants that we funded are those that are looking at the genetics of cancer and applying machine learning to that. Another one looks at how to identify major adverse cardiac events very early, especially in the rural population, through the use of wearables. Those are just some great examples. We're early on in this process. We've been giving out pilot funding just for 1 full year now. We're in the process of implementing our 2nd year, but these teams have made great progress. They've had publications, posters, and are preparing extramural grant funding. So I'm just really proud of these teams that we put together. And even those that we haven't been able to provide funding to yet, they're off and running as well.
How do you see that transforming these two institutions? And is it unusual to see two bigger institutions within a state working together this intimately?
Well, I think in some ways it is when you look at other states and other areas. However, I think it makes a lot of sense for Clemson and MUSC, and we do have a long history of collaboration with them. So, in a lot of ways, this is really building upon previous relationships in biomedical engineering and drug discovery and other areas. I think in one of the reasons why Clemson and MUSC fit so well together is that Clemson doesn't have a specific medical school necessarily, and MUSC is not part of a larger undergraduate and graduate school. We're just a health university. And so it really is a perfect pairing of synergy in that way, because it became very apparent to me in the early days of starting the hub, when I would talk to experts at Clemson that are interested in doing machine learning biomedical research, they don't have access to clinicians. They don't have access to the data. So not only can they not get their hands on good data, they can't get interaction with domain experts to make sure that they're headed in the right direction with their research and building tools that we're really going to use one day. And really, those that will help people. And so I believe that pairing, especially in this area, makes it almost a no-brainer and has worked extremely well.
Excellent. You described that, yeah, very, very helpfully to us, Dr. Baker. I'm really curious to understand how some of these research-based programs are now starting to move into the practice, and where are you starting to see some of that happen, either within MUSC Clemson, partnership arena, or even outside of that in the applications that you were describing from industry or from startups. Can you give us some examples of where you're starting to see some of the AI move into actual practice?
Yeah, definitely. It's a great question. I think some of the earliest tools were based on computer vision or analysis of images, and we've seen those implemented quite successfully in a lot of different software suites. Those that can identify diabetic retinopathy, those that can identify various findings on chest X-rays and CAT scans and MRIs, especially of the brain. There are even more complex solutions that are coming to market through collaborations between industry and academics, and one in particular at MUSC that Dr. Adam Matuskowitz is working on, and had some assistance from the AI Hub with a startup, is looking at evaluating chest pain in adults as they come into the emergency room. So you can imagine that's an enormous thing to take on, a very complex problem. It's not simply a very selective task, like can you identify a very specific diagnosis on a very specific scan. This is taking a huge heterogeneous population of patients that could be coming in from everything from a little bit of heartburn all the way to a full-blown myocardial infarction or heart attack. And so what this tool is designed to do is aid the clinicians that are dealing with these patients by helping them figure out what the probability of each of these complex diagnoses given the patient's information in the EHR. It's really a pretty revolutionary thing. I think that's a great example of how you're going to see these very soon becoming part of the clinical workflow. I think there are, some simpler ones that are even already part of the clinical workflow that have been integrated into the EHR that are not as obviously machine learning or artificial intelligence, but are helping behind the scenes. And then I think, the area of the patient experience is one in which I hope to see, and we are starting to see the effects of how machine learning can improve care. I think specifically in the area of chatbots powered by large language models that could interact with patients and providers to help them move in the right direction with chronic disease by prompting them, interacting with them, supporting both clinicians and patients.
Do you have an example already in that area of chatbots? I find them fascinating because I guess we're all using them, particularly like say with financial institutions. Some seem to be pretty robust, and then others are still falling flat, and they just give you a short list of, hey, is your question in this area? But in the medical space, I would think it's so much more complicated. So are you seeing any examples with any institutions that are using chatbots or for any particular disease area where the conversation is more than just a perfunctory, hit a number and, make a selection?
Yeah. It's a very interesting question. I think you really hit the nail on the head there because it is complex. And in my opinion, in order to have a successful chatbot, and that's one that patients want to use and want to interact with, it has to feel supportive and real and not artificial, right? I think one of the keys to doing that is starting in a particular area, not saying, oh, we're going to, interact with a patient that has 5 different medical problems and tackle all of those. But a company that I'm actually meeting with next week to talk more about their product, they started by looking at maternal health. And so, in that postnatal period where so many little things can go wrong, and a lot of support is needed, especially not only in the hospital, but out of the hospital. They very successfully integrated a chatbot tool that also has a component of organizing the patient's care. In my opinion, in their examples, it seems to work very well and has been widely accepted in the institutions that they have implemented it, and that they have gotten great feedback. I think it's one of the other important things is iterative process of development, right? You're never done. You can't just build a chatbot and shoot it out there. You have to constantly be getting feedback. Also, pretty much everybody suddenly knows about large language models now because of ChatGPT. That was something that's been going on for decades, but now has really become something that everyone is talking about because I think now at this point, probably a majority of adults have at least tried to use it and interacted with it. Maybe not a majority, but an awful lot of people. And it's pretty mind-blowing if you haven't interacted with a large language model. As those become more and more developed and you have APIs and ability to interact with those and integrate them into biomedical chatbots, healthcare-based chatbots, I think you'll see that really take off. Because I don't know if either of you have had the opportunity to play around with it a little bit, but it's pretty amazing how at times it can work extremely well and sound very, very human in a lot of ways. Now, obviously, you need a lot of oversight with large language models like that. And we're still a ways off by just letting those loose in the biomedical healthcare space. But I think the potential value and the potential positive effects, we're starting to see just how enormous that could be if they're used appropriately.
2 questions related to that. With the chatbots, whenever they are so human and are handling a large portion of things pretty effectively, at what point is there oversight? Do doctors go through and review those transcripts, or are there people to see if there's something that they might have missed or might have misinterpreted? And then I think it makes total sense that you were saying they started that chatbot with the maternal population because in general, stereotypically, they're going to be younger patients who might be better with technology and have access to technology. But how do you then apply those types of technologies to a population of older people?
Great questions. Yes, there needs to be a fair amount of oversight. And of course, it needs to be paired with the potential risk, of course, right? And so, those interactions do need to be monitored and reviewed and make sure that you're optimizing the interaction. Also, it is not as complicated as you might think to build in safeguards and have those conversations directly routed to a human. If at any time it seems as though they're going out of an area that you are comfortable with them handling. So I think it's easier than you might think to implement those and mature them in a safe way that's not going to lead to any patient harm. Now, you're right. A lot of it has to do with the population on the other end of that, right? Because if they're not using it, what's the utility of it? In my experience, and I think there's some research to back this up, that there is a bit of a misconception about the elderly's population and their fear or hesitance to work with these types of tools. Some of the smartest folks in machine learning have told me over and over again, the best machine learning is the kind that you don't know is there. It just seems like magic. It works great. And when you provide tools like that, nobody cares if they're AI machine learning or not. It's really what they're able to help do and accomplish. And so if you have the right user interface, I don't think the older patient population will have any real hesitancy. It's just about that whole process of human-centered design, patient-centered design. We need to figure out what they want, and that takes time and effort, and it might not be the same product or chatbot or interface that works for the new moms. And I think that's where the human component is so important, that we need to play a huge role in designing, overseeing, and using these tools, because they can help us enormously. But if we implement them too quickly and don't take the time to design them in a way that is directed towards specific populations and cater to them, they could flop.
Yeah, Dr. Baker, I'm intrigued by your answer. I actually have a kind of similar question as you were talking through that. What I'm wondering is the outputs are really only as good as the inputs, right? So how do you ensure that your machine language learning models have adequate data that covers the breadth of the population? In South Carolina, I'm sure you have such a diverse population, but how do you make sure that race, gender, things like sexual preference, all those kinds of things are taken into account as you're studying the kinds of patients on whom you would apply these? So is that a particular concern? I mean, many of us, wouldn't be able to figure out how to deal with such massive amounts of data, but how do you see, you as the folks who are providing the guidance and consulting to these companies, ensuring that they're really training their models on adequate streams of data?
Very important topic. And one of the main components of that is bias, right? We've seen bias well before machine learning. It's been integrated into algorithms that we know have provided racial disparity care, right? It's been documented, and unfortunately, if machine learning is implemented if models are trained on data with bias, then we could just add fuel to this fire, right? Fortunately, I think the community of machine learning experts and data scientists in biomedicine and healthcare are very aware of this now. We've had some great work that's been done that has shown in just research and not necessarily upon clinical implementation that there is the potential for significant creating significant disparities through this bias. And so there are a number of different ways that have been, that address this issue. Number one is simply being aware of it. You have to constantly be aware of it from the very beginning of building your algorithm to the very end of putting that into clinical implementation, and all throughout its life cycle, right? Because bias can even creep into an algorithm. And so, just the fact that we're getting the input from ethicists and that sort of thing from the very get-go on these is, I think, the way to go about this. But it's really data diversity too, right? We now need to be responsible for data diversity. We can't simply say, okay, well, I'm going to look at a population between this year and that year. I'm going to gather patients and I'm going to train a model that's works on a particular task and can provide a diagnosis without knowing the diversity of that data. And so there are old methods and new methods of ensuring that you have data diversity. There's even methods of creating synthetic data to augment that diversity. And this is a very important topic that is largely discussed at the numerous conferences in this area. And so I think the future is bright for that. I think that we've identified it. And more importantly, I believe that institutions will be on top of this as they begin to implement these tools in the clinical realm. Even if we've done everything we can do to ensure lack of bias, we need to, continually test and monitor that process to make sure that that's not happening.
Do you include patients on these panels and the groups that you're helping so that you can make sure you are getting live human input?
Yeah, definitely. And I think, the two areas, if you're really looking to design a clinical tool, two areas that need to be included very early on in design is exactly what you just said: patient population, and, not only your targeted population, but, in my particular area, since I'm in pediatrics, you have to look at the patient and the parents and the family, all very important. But I also think that the ethics is important to have as a part of this, a bioethicist. They don't have to, be there at every single research meeting, et cetera, but to have interactions with those folks to make sure that you're doing everything you can to look at the important ethical implications. And it goes well beyond just bias and data diversity issues. You can see the issue arising in things as simple as patient consent, right? When you have a tool that is completely autonomous, that puts in a new component in the patient physician relationship or patient provider relationship when you're obtaining consent, because it's not necessarily me anymore that might be making all of these decisions. It might be a decision that's provided to me by a algorithm, and then I have to decide whether I think that is the best course of action for the patient, and it almost enters in another agent into that process. And so much to think about. So important to get large, diverse teams to tackle this sort of thing. Not only ethnic diversity, but background diversity, right? Machine learning experts, ethicists, patient population representative and liaisons, clinical domain knowledge. These can't be built in isolation with just a few folks on the team without having all the important areas represented, because if you don't, that could be a recipe for disaster for a tool that could wind up, potentially.
Dr. Baker, I'm actually just fascinated and really impressed with the breadth of what you're covering through this through the hubs, because you have to look at all the technical components, the clinical components, the ethical components, and the human aspects as well. And you're describing them so nicely and eloquently for us. So really thank you for that. My question actually is on the human side, coming back to that. I think you covered so many aspects of it. But the one thing that I often worry about, especially as we work with so many doctors and nurses in clinical practice, is the acceptability or the acceptance, I should say, of the physician for these tools. Are they actually willing to use the outputs? Are they trusting enough of them? Are they willing to try to slow down long enough to try to insert these tools into their workflows? And so maybe you can talk a little bit about how you gain the physician's engagement and willingness to participate in the process as well.
That's a great question. I think you've identified the potential Achilles heel of a lot of these tools, right? You can design a beautiful tool that has, just incredible accuracy, but if you don't integrate it effectively into the clinical workflow in a way that the provider is going to be able to interact with easily, it could just go no place. But fortunately, this is not the first tech to have that issue, right? EHRs pave the way. And that was a very bumpy road at a lot of institutions. I think any provider that you talk to probably has a few complaints. Now, there's also a ton of wonderful things about EHR, and I'm actually a huge proponent of it. Not only do I think in the end, once you get over all those moguls and bumps, it's a better way to provide care, but it is a much better way to collect data. That's for sure. And that's what's going to power all these tools in the end, right? But to answer your question more specifically, I thought a lot about this and have given lectures on it. I think it's very interesting, because I have the physician perspective, but there are people whose expertise is in this area. And that's who we need to tap into, because although there are some new aspects that go along with AI and machine learning that you hit on specifically, which are, it could provide a diagnosis without, a complete diagnosis, which is a different interaction. Physicians aren't used to that. They're used to getting information to integrate and come up with the diagnosis. But this process has been done before, and we need to stand on the shoulders of those giants that have already tackled these huge problems, because it's not terribly different. And I from my perspective, from my clinical hat on, it's all about workflow and timing, right? You really need to respect the fact that providers at all levels are just pushed to the max right now. And so you need to lead with how this is going to make it easier, but not just say that, actually make it easier for them for a few days, and be there by their side and show them how it makes things easier. And then you'll see these successfully implemented. And of course, the patient side too. When your patient's happy, as a provider, you're happier, right? So if you see this process helping your patients and helping you interact with them better, the chatbots, for example, that we talked about that someday might be powered by these large language models, once you have that time, you're not having to respond to as many straightforward, simple things. You can really focus in on those important ones. Boy, that's the patient I need to spend 20, 30 minutes with on the phone. And now in the future, you might have that time much more readily than it being, at 6 or 7 o'clock when you want to get home to your family and have dinner and that sort of thing. So that's where I think that if we look at it with that sort of foresight and team up with these people that have already done it, that's how we're going to solve that problem.
What fuels your personal passion around this? Because you are clearly very excited about this and the opportunity that it can bring to everybody involved in healthcare. So what drives you to keep going down this road?
Well, yeah, you may have opened another interview there, because it's hard to put this succinctly. But I encountered this area a little bit per chance. I attended a conference. I have to give credit to Dr. Anthony Chang of AI Medicine organization that was started a long way back now, about getting AI into medicine. But long story short, I went to it a bit skeptical and left a complete believer in this area, and went on to get a master's in data science. I think what fuels my passion is the potential, right? I think the potential is huge, but also the need to implement these tools, create them, implement them, and monitor them in the right way is going to completely determine the success or failure of AI in medicine. Now, I don't think failure is really an option or realistic, because AI is not going anywhere. It's hugely important, but it's more the time span, right? Are we going to see these benefits in 5 to 10 years? Or is it going to take 10 to 20 because we didn't do it right the first time around or the first few times around? And that's really where my passion is, to make sure that the awareness is there for everybody, that you don't have to be a machine learning expert to understand how important this stuff is, and how much it could help us if we all work together and do it right. My own project that fuels my desire to keep the research infrastructure at these two institutions and the entire state of South Carolina building is in congenital heart disease. That's what I work in, and we're designing a computer vision model to diagnose particular congenital heart defects autonomously by ultrasound or echocardiography. We're in the very early stages, but I got the background, through doing that master's, and just found it fascinating. And now this opportunity to truly apply it in my own area, I'm even more excited than I was before. So I don't see my passion lessening at all.
Thank you so much for being here and for sharing this conversation with us.
Thanks so much for having me. It's been a blast.
Wonderful interview. Thank you, Dr. Baker.
And
Thanks.
we'll talk to you soon. Bye-bye.